afternoon. This is Robin Whittemore, and my talk today is going to be on a diabetes prevention program in the community. I would like to acknowledge my colleague on this project, Alana Rosenberg, who has a master's in public health and has had a great influence on the ability to help me do the community-based research that is part of this project. Most people are aware that there's an obesity and type 2 diabetes epidemic in the United States and worldwide. Ethnic minorities, particularly Black and Hispanic minorities, are at a greater risk for developing type 2 diabetes. And we now know there's compelling evidence that demonstrates that type 2 diabetes can be prevented with lifestyle change and weight loss of approximately 5% of body weight. But there still is a great need for type 2 diabetes prevention programs for ethnic minorities. So the purpose of our study was to evaluate a diabetes prevention program that was provided by home care nurses to residents of subsidized housing, therefore reaching a marginalized population who may not have access to these types of preventative services. We used a participatory method involving the targeted users in the development of the program. So we had focus groups with residents of subsidized housing, home care nurses, and also other professionals of the community related to subsidized housing and or diabetes prevention or education efforts in the community hospital to develop our program. We then conducted a study, what we consider to be a pilot study with cluster randomization, comparing the modified diabetes prevention program to an enhanced standard care program. And the development of these programs were based on the diabetes prevention program and a lot of the outreach and educational materials that have come as a result of that effort from the CDC. We used these platforms or these developed programs and the results of our focus groups to then tailor the program specific to the needs of this population. And so our experimental arm, or the diabetes prevention program, we provided with 7 group classes that were provided over 6 months. These consisted of education, self-monitoring, and behavioral support. And our enhanced standard care was primarily just an educational program of just 2 group classes that talked about diabetes risk and healthy eating and physical activity with a little bit of self-monitoring addressed as well. But the major difference between the groups was the overall content that was provided and the behavioral support, which consisted primarily of goal setting, as I mentioned, self-monitoring, and problem solving. We recruited 67 participants for this study. This table here describes the demographics of our sample. We were 79% female with a mean age of 40 years old. They were of diverse race and ethnicity. 76% were non-white. The majority had a high school education. However, the majority were also unemployed and of low income. 83% were unpartnered or single, which means they were either never married, divorced, or widowed. And there was an average of 3 children per participant. The majority, which was a very surprising finding for us, 51% had elevated depressive symptoms. And this compares to a national average of maybe 10 to 20%. And is higher than what has been reported in other studies that have looked at adults at risk for type 2 diabetes. While I don't have this information on the slide, our quality of life measures of both physical health and mental health were well below the national averages as well. So, highlights or points out to the vulnerability of this particular population. This is just a little bit more detailed description of our racial ethnic distribution of the sample. We had 15% Black, 47% Hispanic, 24% white, and 14% were multiracial. When we looked at the comparisons between our groups on variables, they were comparable on all variables except race and ethnicity and gender. And this isn't surprising because with subsidized housing, particularly with the race ethnicity, there are different race ethnicities that seem to live in different housing communities. And so we had more Hispanics in our standard care, and then more of all of the other race ethnicities in our diabetes prevention group. We also had more men that were in the diabetes prevention group than there were in the standard care group. And so we will be controlling for this in our future analyses. Since we recruited adults at risk for type 2 diabetes, we would expect the majority to be overweight or obese. And sure enough, 64% were obese with a mean BMI of 33 kilograms per meter square. This slide shows the percent of participants with abnormal clinical outcomes at baseline. We had 57% that had elevated systolic blood pressure, 39% elevated diastolic blood pressure, 58% did not meet the physical activity recommendations of 150 minutes per week, and 87% do not meet a low recommendation of 5 fruits and vegetables per day. We have not run any of the lab data yet, as we are just finishing up the 6-month data collection, and that needs to be run in a batch. This shows the attendance for our program, and attendance at classes was suboptimal in this high-risk, vulnerable group. Typically, in this type of an intervention, we like to see 70–80% attendance, and you can see for our standard care, which only had 2 classes, we had 60% attendance, and for the diabetes prevention group, we had 54% attendance. You can also see we had much better attendance when we broke down the diabetes prevention group for the first 3 months and then the second 3 months of the program. However, if a class was missed, the workbook content was delivered to participants by our community health workers. And I don't have any slides to share with you on our results, as we are just finishing up the 6-month data collection. But our preliminary results of our short-term follow-up indicate a number of significant improvements in both groups, particularly with dietary behavior. We saw a significant increase in low-fat eating, meal planning, fruit and vegetable intake, as well as a significant decrease in fast food and unhealthy snacking. We had a trend towards improvement in both groups with physical activity and a decrease in waist circumference, but no effect on weight at 3 months. And at 3 months, the only behavior that improved more in the diabetes prevention program was sedentary behavior. So we'll be completing the 6-month data analysis soon, and we'll see if there's any further differentiation effect of the program with longer-term follow-up. So what's been the impact then of our program? Well, it's still early to determine the overall impact because we have to finish our analyses. We have demonstrated the feasibility of developing a partnership between home care and subsidized housing. We also have provided diabetes risk assessment in subsidized housing. We screened over 200 people in the early parts of the study. We've demonstrated the feasibility of providing the diabetes prevention program by home care nurses in subsidized housing. And we have improved eating behaviors and physical activity in diverse adults at risk for type 2 diabetes. And this is despite multiple comorbidities, including, as I mentioned, the high mental health problems in such a young population. And considering that this is a relatively low-dose and low-cost program with an adult sample with multiple children, we do feel that there's a potential for high impact for the program. So who's our audience? Who do we want to reach out to then to further our efforts? This would be certainly diverse families, particularly those that are living in subsidized housing. We also would like to reach out to home care nurses. The nurses that we worked with the program were really delighted to see the possibilities to integrate more diabetes prevention in their other work that they were doing. And we also hope to reach out to other home care agencies, in addition to our partner at the VNA East. So how do we propose to reach our audience? Well, we certainly will disseminate our results in the typical ways of presentations and manuscripts. But we're also working at packaging our education and behavioral change workbook with plans to distribute this to our community health agencies, our home care agencies, and the directors of the community centers of subsidized housing. One of the things that really came out of this study was an awareness of the potential of these community health centers, or these community centers, that are located in subsidized housing, and they are very much underutilized, and we have great potential to serve as a platform or a mechanism to get more health promotion programs to the residents. We also would like to provide more education to home care nurses. Again, as I mentioned, our home care nurses that were part of our program or part of our staff, had really not been doing any diabetes prevention efforts in any of their practice, and they really saw the need and the potential for this kind of program that could be offered in other ways in some of the work that they were doing. So we plan to provide a community health a CEU program on diabetes risk assessment and diabetes prevention in home care, as well as develop and distribute a toolkit on the diabetes prevention classes. And we feel that our classes are such that they could be provided as a single class, so if a nurse wanted to go out into a community and just do one class, or they could be developed to be provided as a whole program. We also, again, hope to provide some dissemination to other home care agencies. We'll start in the state of Connecticut and outreach from there, again, depending on what our results are of our study. But we hope to provide a webinar on diabetes risk assessment and diabetes prevention in home care. And then the other thing that we hope to do is that there's a big national initiative right now to prevent admissions to the hospital in home care, and certainly health promotion and diabetes prevention could be part of that. So we'd like to try to align some of our messages with that national initiative. So what's next? Well, certainly, again, like I mentioned, we need to complete the data analysis, our presentations, and our publications. But I also want to explore strategies to provide more health promotion in community health centers of subsidized housing. As I mentioned, I feel like there's a very underutilized resource that's available in many of these communities. The other thing that we hope to do is explore mechanisms to address the high psychological comorbidity in this population. Considering the link between depression and insulin resistance and depression and type 2 diabetes, this needs to be an important focus of our future work. We are currently conducting a secondary study interviewing those participants of this study who had increased depressive symptoms, and we're looking at some of their causal beliefs, some of their past history, some of their access to care, and some of their perceptions of treatment to, again, help us to figure out what kind of strategies or what types of programs we need to do to address this significant problem. And then the other thing that I've begun to think about is ways to try to link schools of nursing with home care nursing and subsidized housing, in that it seems like we could develop a APRN, RN model of care whereby we could have nursing students that could be doing some of the health promotion that is greatly needed in these communities. So that's my presentation, and I'd like to acknowledge the fabulous team that came together to complete this project. As I mentioned, my collaborator, Alana, as well as my nurses, Vicki and Lisa, my research assistants, Kelsey and Rachel, and all of my community health workers, particularly Miriam, who really went above and beyond what was needed to help us complete this project. So thank you for your time.